I thought I was really good with kids. And then I went to pediatric ER. They're rough. They'll beat you up.
It's like wrestling like a 3-foot alligator.
Yep.
That is screaming bloody murder and spitting everywhere.
You're not going to win.
Hey guys, welcome to Nurse Talk, the podcast where we talk all things nursing. I'm your host, Mia, and today we have Lyndsea.
Hello.
Thank you for coming.
Yes, of course.
So I start off every time with why nursing?
So I ended up in nursing kind of in a very odd way.
Okay.
So I always wanted to go into nursing. Even when I was really little, I was gonna be a pediatrician. So I was always interested in the medical field. But then I got to college, and I actually I started my freshman year. I took a bunch of courses that were just like my gen ed courses. One of them was chemistry, and I got a D. And so when I went to go transfer to USF the next semester, I remember meeting with like the pre-nursing advisor, and she was like, "You'll never get in." She's like, "Don't even bother." I wish I could remember this lady's name because then I could go back and tell her like I did it.
Oh, absolutely.
But I remember my dad was with me, and she just looked at me and was like, "Don't even bother." And I was like, okay. So I just changed my major. I think it scared me, and I was like, okay, I guess I'm not going to do this. I guess I can't. So I majored in psychology and criminology, and I finished my degree, and then I worked in that field for a few years, and then decided to go back to nursing school because I was going to prove her wrong. So.
Oh my God. What did you do in criminology?
Yeah, so I was a victim advocate for major crimes for one of the sheriff's offices. Mostly worked with crime scene investigations, supporting families, giving them resources, and then following them through the court system. And then after that, I was a child protection investigator. So I investigated allegations of abuse, neglect, and abandonment.
Oh my God. I didn't know that about you. That's amazing.
Yeah. And then I said, I need a life. So I went into nursing because I thought working 3 days a week was great until I went to night shift.
That takes over your whole life, and
Yes,
you, again, do not have a life.
No.
So why NICU?
So I think it was just for me the natural step, knowing that I had always wanted to work with kids, knowing that I had always had a passion for substance-exposed newborns. And that was a specific population that I was like, if I'm going into nursing, that's what I'm going to do. And so when I was finishing nursing school, I did have that debate in my head of labor and delivery, NICU nursing, back and forth. And everyone kind of discourages you when you're finishing nursing school from going into a specialty directly. They always say start med surg, but I just knew that that wasn't what I wanted. And so I had the opportunity when I first graduated to go either postpartum as a nurse, where I was a tech prior to that, or I could go NICU. And NICU was always just kind of my heart. And so I went NICU.
Oh, so what would you say is your favorite part of being a NICU nurse?
The families. And I say that because I don't think I ever would have known that that was my favorite part until I later transferred to the pediatric ER and didn't have a lot of time to build relationships with families. Then I quickly realized that that's what I missed. So I really missed the time that you get to spend with these babies. You get to watch them grow and change and like just get better and improve. And then you get to watch them go home with their families. And by that point, you're getting invited to first birthday parties and, baby dedications and just stuff like that. And to me, like you kind of become a part of their family, their extended family. And that was just always such a really cool experience.
Absolutely. You feel like an aunt almost.
Yes.
Yeah.
And some of them do call me aunt.
I know. I think I've seen you go to like quite a few birthday parties.
I love it. It's so fun because you get to see them like outside of the hospital. And sometimes it's one of the first times that you get to see that. You take care of them, and sometimes it's a short time, sometimes it's a long time. But then you see them living their like normal life and just doing what every other baby does. It's really cool.
And it's so amazing to see them live just an absolute normal life when that probably wasn't plausible at some point in their care,
A lot of them, for sure. A lot of them, you don't know how it's going to go. And so they're all miracles.
Absolutely. It's the best job ever.
Yes, I agree.
What's the most miraculous turnaround you've witnessed in the NICU?
I've had many, many babies that we just didn't think were going to make it and are thriving now. Like, I feel like I see it happen over and over and over again. They're just such little miracles. They're so much more resilient than we think. I mean, everyone talks about kids being resilient. I have friends that are pediatric nurses and pediatric intensive care unit nurses, and they're like, kids are resilient, kids are resilient. And I'm like, you hear that, but then like you see it firsthand and it's so cool. You see them go from like their parents having no hope to like they're going home, and you just never saw that coming.
Oh, absolutely.
Or like the moments that they take their first bottle and you're like, will they ever take a bottle? And they take their entire first bottle and you're like, oh my gosh, it's so cool. So
it really is.
Yeah.
Do you have any memorable stories you'd like to share of the NICU?
I feel like most of my memorable stories from the NICU are with my coworkers. I had the best coworkers in the NICU. I had so many friends that like I built relationships with that they became so much more than coworkers. They really became friends, some family. And I still, like, even after I've left that unit, like get together with them or get text messages from them of like, hey, how's it going? Or just the other day, I'm actually in the process of getting licensed to be a foster mom. And one of my coworkers was like, I have all this stuff for you. Come pick it up. And gave me tons of clothes from her kids and toys. And it was just so sweet. So it's really neat to see how like that community, when you go through some challenging experiences together, it's almost like a trauma bond.
Oh, absolutely. Yeah.
you get to like build those relationships that you would not have built otherwise. I have relationships with my coworkers from the NICU that I've never had with other coworkers. For sure.
Especially Madison.
Yes.
Sweet Madison.
Yes, my buddy. Even when I was working nights and she went to days, we try regularly to get together for breakfast or to go to dinner. We have our two favorite places. And we always just try to make time to at least, I would say once a month, once every few months, we try to get together and just catch up and share stories. So,
yeah. Okay. So why did you decide to leave and make a change?
Yeah. So originally when I left NICU, I went to the Pediatric ER. And for me, I thought that it would be kind of a step for me. My goal, what I thought at the time was my goal, was to do pediatric trauma transport.
Oh, wow. Okay.
So I was interested in NICU nursing transport, but also pediatric transport. And so I thought that that would be like the next step to get that experience. Then when I got down there, I very quickly realized that that was not my goal anymore. I did not like, actually, I could not stand that you didn't get any time with your patients. And so many times, like, I just didn't even get a chance to know my patients' names.
Oh,
and
wow.
to me, coming from the NICU where I know my patient's name. I know their story. I know what blankets they like. I know what passies they like. I know what position they like to sleep in. I know what makes them mad. I know when they're not feeling well. And then to go to the pediatric ER where I know them for 2 hours and then they're gone and I may never see them again. I didn't realize how much I valued that connection with my patients and their families. And I was like, this is not for me. And then I realized that pediatric transport or NICU transport would be the same thing. I would not get that time with my patients.
So what are some of the most common things you would see in the pediatric ER?
The pediatric ER, it's so funny because I feel like things come in waves.
Okay.
At least from my short time there. But I feel like sometimes you see kids that come in with, I mean, we're a pediatric trauma center where I work. So you see people who come in with like very, very serious injuries, but then you also may have kids come in who aren't able to get into their pediatrician and are coming in with just their parents are scared because their kid is sick and they're not able to get into their pediatrician because of scheduling or whatever the case may be. And it's just a very like minor illness that really could be seen at the pediatrician, but they weren't able to get in. So you kind of, I feel like you get both ends of the spectrum and everything in between. I mean, just like any ER, I mean, you're going to see your typical, cold and flu, you're going to see broken bones, you're going to see burns, you're going to see traumas, car accidents, you're going to see all kinds of stuff like that.
Oh, okay.
Yeah.
How long were you there?
I was only there for a little over a month.
Oh, okay. I didn't realize it was
really short time.
I didn't realize it was so short. Did you notice a difference in coworkers and relationships from NICU to PD ER?
Yeah. So you go from an ICU environment to an emergency room environment. So I was kind of in shock. I thought I knew what to expect, and I did not. You go from an ICU environment where everything is very, very detail oriented and everything is very specific to each patient. Okay. And then you go to the Peds ER where it's all chaos. Okay. You're just, your goal is to stabilize and either admit or discharge. Like that's what you do. So the details are not really a huge thing. I mean, obviously both have different policies, procedures, protocols, things like that. But your goal is very different. Your goal in the ER is to stabilize and admit or discharge. And your goal in the ICU is that long-term care. With that, you have different personalities. Okay. You have people who enjoy doing that long-term care, and then you have people who enjoy just kind of getting in, getting out. And I kind of thought that I was one person, and I kind of figured out that I wasn't. And I was like, wait, I miss my patients. I miss time with them. Like, I like the pace of the ER. I like that it's fast and it's fun. Fun is probably the wrong word. Fast and exciting. Fast and exciting. Exhilarating sometimes. But also very stressful because you never know what you're walking into. You could walk into an ER full of patients, or you could walk into an empty ER.
That would be crazy. I would not like the pre-shift anxiety of that at all.
I had a lot of pre-shift anxiety with that one. Yeah. And I think that was like a big part of it. I just was like, oh, I don't know if I can do this long term, not knowing what to expect. And I feel like in NICU, you knew you were either going to get, I mean, the ratio is usually 1 to 3. And so you were either going to get 1 super sick kiddo, or you were going to get 3 almost ready to go home little feeder growers. So you knew what to expect. Whereas, and we always had babies. We never didn't have babies. We always had babies. And so it was definitely a weird transition and lots of different personalities.
What qualities do you think a nurse should have to thrive in pediatrics?
Pediatrics, you have to have a passion for kids and for families. And you have to have a lot of patience because you can't... And NICU and pediatrics are a little bit different because NICU, the babies can't talk to you. Pediatrics, they can. And they will be terrified of you.
Was that surprising to you when your patients were all of a sudden saying?
So surprising. I will never forget the feeling of kids just being afraid of me because they knew I was coming to poke them. Aww. Like, it was awful. Whereas in the NICU, they don't really understand that. And so it's a little less traumatic. Like, you still feel very bad, but you know that you're helping them. Whereas in the pediatric world, they know that they don't like you. They know that what you're coming to do is not going to be fun, even if it is good for them. They don't understand that unless they're much older. And so that and just like the age ranges are so variable. And so it's very interesting to see, like, you have to be very versatile because these kids all have different personalities. And you may have a tiny, tiny baby and you might be working primarily to comfort the parents in a scary situation. Or you may have a 16-year-old who is on their own. And so you're dealing with completely opposite ends of the spectrum. And so I think you just have to be very flexible, and you have to be very passionate about what you're doing, just because these kids can be tough. And it can be hard and heartbreaking, and because nobody wants to see kids hurting. And it's just, I think that you just have to really love it.
Was one age range harder than the other? I feel like you just love all kids. So I do. I feel like it's not a fair question for you, but
I do love all of them, but man, those toddlers are rough. They are something else. They have figured out that they have a voice, and they are going to tell you like it is. That, like, even up to like preschool, I would say like ages 2.5 to like 2.5 to probably about 5. They're rough. They'll beat you up.
Yeah, I got floated to, peds med surg, and, I don't have any kids in my family. I don't have any kids of my own, and I've only done adults and NICU. Yeah. I've never done any in between.
Yeah.
Some of my friends have kids, but it's like, I'm not doing like medical care to them. So anyway, I walk in. I'm so nervous. It's my first float ever. And they give me a 2-year-old. No, none of the family's in there. And they're in that big old like kind of crib where, you walk in and the things are all the way up high. And I'm like, I don't even know how to use this bed. And so she has pneumonia and COVID. So I'm all, PPE. And I'm like, oh my God, I don't even know what to do with this 2-year-old. She's standing up at the gate, like looking at me. And
like, I know what you're about to do.
And I'm like, oh my God. And she's like, snot. And she's looking at me like,
oh, baby.
And I'm like, oh, okay. And I have no idea what I'm doing. And I'm like trying to open the thing. And I pull it down and she just literally like jumps onto me and hugs me. And she was so sweet. And I was like, oh my God, this is so different.
Sometimes I wonder if in pediatrics, we're talking them off a ledge or ourselves off a ledge. Because you're right. Like what you were saying about taking care of kids in a medical capacity versus taking care of kids. Like I nannied for years. I've always taken care of kids. I thought I was really good with kids. And then I went to pediatric ER and I was like, I am terrible with kids. I was like, you have to convince them to let you use a stethoscope to listen to them.
Oh, yeah.
They like...
And the whole time they're squirming and like, and you can't hear anything because they're moving.
Oh my gosh. The other day, one of my really good friends, she's a little one, she's 2. And I was over there and she calls me Winnie. And so she's like, she knows Winnie's a nurse. And so she was sick. And my friend is like, hey, like, do you think you could put some saline in her nose?
Oh, God.
And I was like, yeah, for sure. Absolutely. And she wanted me to listen to her and just make sure her lungs sounded clear. So I listened to her and I was like, yeah, girl, she's good. And then she asked me to put saline in her nose. Girl, it was way harder than I thought. She saw that saline and she was running through the house and she was losing her mind. And I was like, it's okay. Like, and then I tried to like, let her do it to me. I tried to let her do it to the dog and like, oh, like, look where, and no, it was not a pretty sight. And I was like, yeah, it's a whole different capacity.
Oh, absolutely. Yeah. I'm like, I don't know what to do with these kids. No. Absolutely not.
It'll be interesting when I become a mom one day.
Yeah, to like try and use those skills. Like,
yeah,
I feel like the kids like look at you like kind of funny when you walk in the room, and then like now I'm looking at myself funny, and I'm like, I don't know how to talk to you.
Giving medicine is another one. Like, I remember in the peds ER just having to give like kiddos like Tylenol and stuff, and like when they don't want it, you're not gonna get it down them.
Oh, I know.
They will spit it out at you. Like, they do not play.
I had a 1-year-old do that to me. And I'm like, you're smart for a 1-year-old.
Yeah, they see it and they know. You're like, it tastes like cherry. It's fine. Nope. No.
Literally, they were like,
yeah.
And I'm like, no.
Yeah. And you have to figure out how to like put it in. So it's just, yeah. It really, people think, it's so funny because like kids, you're like a little bit off the nursing topic, but kids are like, or other parents, I should say, or other people even like who don't have kids. They're like, oh, well, you just need to like be tougher on them. Like you just make them do it. And I'm like, I'm pretty tough on them. Like I have a bunch of little bonus nieces and nephews. And I'm like, I feel like I'm pretty tough on them. And if they don't want it, it ain't happening.
Oh, absolutely. It's like wrestling like a 3-foot alligator.
Yep.
That is screaming bloody murder and spitting everywhere.
You're not going to win.
No. Might as well just get an NG tube, strap it inside, give them the med.
That would be easier. That would be easier.
Even though they just rip it out like the babies do.
As long as I get the med and it's okay.
Can you walk me through what sparked your interest in labor and delivery?
I thought I would venture out and I was like, okay, let's see where this all starts. I was like, these moms, a lot of times when these babies are born, we in the NICU, our job is to care for the babies primarily. We care for the families too, but obviously the baby is the priority. That's your job. And so I would notice that moms would come in and they would just be so scared, or they would be in a lot of pain and also trying to see their baby and just trying to recover at the same time. And I saw like such a need there. And I feel like my heart is always, if I see a need, I want to meet it, which is sometimes healthy and sometimes hard. Sometimes that makes things a little more challenging because you have to figure out how to separate that from work sometimes. But I was like, okay, like let's try labor and delivery. Let's try labor and being on the side of helping the mom through this process, and even helping these moms navigate, when they do have preemies, being able to bring a little bit of that NICU knowledge to these moms and being able to help them. So I went that route and have had a great opportunity to be able to do that and just love on these moms and be there with them. When their baby is taken to the NICU, I get to be there and love on them and support them, especially when their support person ends up having to go with the baby to the NICU. I get to be there with the mom and walk her through some of those next steps, which is really cool.
That's amazing that they have you because, of course, being on the other side, working in the NICU, you'll get this admission, and unfortunately, sometimes the mom can't get there for 24 hours and sometimes longer, depending on, what state she's in. And you just know that mom is somewhere in her room just yearning to see her baby. So
and in the NICU, and I think most NICUs have the camera system where the parents can see the baby. There's some different ones out there, but now I'm like so very intentional when I am over on the labor side of talking to the parents and saying, like, if I know the baby is going to end up in the NICU, hey, like, make sure you ask about the camera, make sure you get the paper signed so that you can do that. That way they don't have to miss as much time, because even though they can't physically be with their baby, at least they might be able to see what the baby looks like. Because a lot of times when these babies go to the NICU, it's emergent, and I would say most of the time, and so they don't even get a chance to really see their baby.
Oh yeah,
they don't even know what they look like.
I know.
Yeah,
that's crazy.
Yeah,
and it also helps with the anxiety. And like, okay, my baby is there.
For sure,
my baby is fine, because oh my God, I can't imagine. They just take your baby and like 24 hours later, you're like still trying to get to bedside to see your baby. So
yeah. And it's been super helpful, I think, too, that I've worked in the NICU where I work in labor and delivery at the same hospital, because then I know a lot of the NICU nurses, and I can say, they'll tell me, oh, this nurse has my baby tonight. And I'll be like, oh my gosh, they're wonderful. Or they are really great about this. And I can really like talk that nurse up so that patient feels comfortable that her baby is in good hands. And also, it helps that I have a relationship with a lot of the NICU nurses, and I can call them really quickly and say, hey, do you have a quick update for me? And so that's really helpful too.
Oh yeah. Absolutely. It's probably very rare that a labor and delivery nurse also worked NICU for that long and has that good of an understanding. Like, oh, you see that IV there? You see the CPAP? Let me explain it to you,
Yeah. And I do love that I'm able to do that, because I realize how much on the other side of it, on the labor side, I just realize how much information they don't necessarily get because of time. So when the NICU team comes in for a delivery, they're there quickly, and then they need to get the baby taken care of. And so they don't usually, they sit down with the mom, but the mom is going through so much at the time that a lot of that information she doesn't retain, or, she doesn't fully understand and has questions about, but doesn't really know what to ask or how to approach that. And so it's great too, because I can call the providers too when mom is, recovering and in a better mental state. And I can say, hey, like, what's the update with this baby? What's going on? I have mom here, and can have that conversation at, a better time, because unfortunately in medicine, time is not out of our control. That is one of those things that we have no control over. So
I'm sure the providers like that too. Cause
and I think it gives them an access where they don't, because they're running around taking care of babies, and a quick phone call is easier, because sometimes it's hard to get a hold of the parents on the room phone or the cell phone even. But if they can have, a nurse that they can directly communicate that with, it's really cool.
That's awesome. Yeah. And you also understand all of like what's going to happen. So if a mom goes into labor at 28 weeks, you can explain, okay, your baby's going to just be hanging out for a while.
Yeah.
And you can kind of give them that, because something I've noticed recently with parents is they'll be like, so when is my baby going to leave? No one's really, and the baby's like a week or 2 weeks old, and you're like, wait, no one sat down and been like, hey, at 33 weeks, we can do this, 34 weeks, we can do that, and yada, yada, and you'll be surprised. So having someone like you that has knowledge on both ends must be amazing.
I enjoy it.
So how do you navigate a patient who is absolutely terrified of childbirth?
every patient is a little different. I think it depends on why they're terrified.
Okay.
And really getting to the root of that is my first goal. My favorite question to ask patients when they tell me I'm really scared is I get the stool out. I sit down next to them and I say, okay, let's talk it through. Tell me what you're most afraid of. And then I try to answer as many questions as I can about that. And I tell them if I don't know the answer, I will either find it out or I'll go get the doctor, the provider, whoever that may be, and I will make sure that we get your question answered. So I think getting to the root of it is really like the best start. After that, you kind of go from there. But most of the time when I sit down with them and I just get on their level and I'm like, hey, like, I'll meet you where you're at. What's going on? What terrifies you? A lot of times people have seen things on social media that have made them very scared. And they think that certain things happen all the time when they're really rare. Various different complications and stuff. Or they've had a traumatic experience prior to that. I mean, it could be so many things. Or it could just be they had a friend who had that experience, or they've been told one thing, or it could be like a very real, ongoing, scary thing. And my favorite thing when I do tell patients when that scary thing is actively going on is I say, I try to have the conversation ahead of time with them. If I see that things are looking like they might be going south, my conversation with the patients is always this: let's talk through what this could possibly look like. This may not happen, but let me walk you through it so that you know what's going on. And I will also tell them, I may not in that moment be able to explain everything that's going on to you. It may be an emergency, but I need you to trust me and that I will take care of you. Our team will take care of you. And after everything is over, we will have a discussion about every single thing that happened. All your questions will be answered. But sometimes in that moment, you just have to trust me. And usually when I have that conversation, they look at me and they go, okay, I get it. and it makes when those emergencies do happen a lot less scary for them. They're still tramic. It's still scary.
There's nowhere to go about that.
But at least they know, okay, she told me that this could happen. She told me that this might be my experience. And she told me that even if there's things that she can't explain, she's going to explain them to me later. So I have found that has been a very effective thing. Someone once told me that, I can't really remember who it is. But when I first started in labor and delivery, that was one of the things that they had told me, and I have used it every single time.
Oh my God, I would trust you immediately. I'd be like, absolutely, yes. When you were telling me that, I was like, I feel it. And I would trust you.
I'm not the one, doing all the things, but I trust our team. And when my patient knows that I trust the team, then I've gained their trust and they know I trust the team, then usually we do pretty well. So
that's amazing. Yeah, I think the part where you said you sat down and got on eye level with them, that's so important. I started doing that more recently, in the NICU, and it's made a huge difference.
You really have to do that in the NICU too, because parents are so scared, and you can explain things a million times and they still might not remember it because it's such a traumatic experience. They've just been through birth, which is scary enough, and now their baby that they envisioned their baby going skin to skin with them. They envisioned their baby going home with them in a couple days.
Or breastfeeding immediately.
Yes.
Yeah.
And bottle feeding or breastfeeding or snuggling on the couch at home. And now they're looking at them through plexiglass.
Oh, yeah.
And it's terrifying. So doing that with parents is huge. And I feel like the more nurses that do that, the better, because you have hopefully nurses that in labor and delivery are sitting down and having those conversations, and then in the NICU as well. And then that patient feels supported. Because once that baby is born, most patients, they do not care what happens to them at all. They just care that their baby is okay. And I do try to get on that level with all of my patients. Obviously, you walk in sometimes and patients in active labor, and you're not going to sit down and have a conversation.
Yeah.
They don't want to have a conversation with you. They want that baby out. And you're just going to do your best to get that baby out as quickly as possible for them. But a lot, if I come in and I have a patient that is just kind of in the beginning stages, or especially like an induction patient, things like that, I really try to, during that admission process, I pause, I pull the stool over, I sit with them, and I ask them about what their plan is for them, for the baby. What And then sometimes they don't know. And so I walk them through what we typically do, what it looks like.
Yeah.
And I ask them if there's anything that they want done differently so that I can relay that to the provider and give them a heads up. If they, things like if they want to take their placenta home or if they don't, if they want to leave the umbilical cord before they clamp it, we usually, we do delayed cord clamping as long as it's safe to do so. And then some parents want it longer, things like that. So I try to have those conversations just so that they feel like they're in control of their labor and delivery a little bit, because even if it is those little things, at least we can make that happen.
Absolutely.
So, most of the time, if it's unsafe, obviously that's different, but I can usually try to, get as many requests as possible accomplished,
Yeah.
and some
course.
people just want to see their placenta, and we can usually get that accomplished, or, different things. And so I try to just be in tune with my patients and make sure that what they want to happen is known, because even if we can't make it happen, if there's a safety concern and we can't do it, then at least they feel like they were heard and someone cared about what they wanted.
Absolutely.
So.
Because in those scenarios, they don't have any control.
Right.
None.
Right.
They're just...
It's a very vulnerable position to be in.
Absolutely.
Yeah.
Has anyone ever yelled anything like funny or hilarious during birth?
A little bit of a different answer to your question. Okay. Not necessarily something crazy that anyone has said, but what has been crazy to me is to see the differences. You can have someone have a natural delivery, unmedicated, and they will deliver quietly, calmly, like it looks like it was the easiest thing they've ever done in their life. And then you have patients who are like screaming and the whole unit can hear. So it's so crazy. It's so funny to me how like you have such a wide range of different, of different experiences, I feel like.
And why do you think that is?
I don't know. I mean, I think that some people do a lot of preparation for a natural birth. A lot of like mental preparation as far as like coming up with different ways of like helping them kind of get in the right headspace with it. Some people, they have like made up their mind that like pain medication is not an option. And so I think when they've made up their mind and they take it off the table, they're like, well, I have to do this. And then I have patients who are like, no, thanks. I don't want to do it that way. And honestly, I'm here to support whatever way you want to have your birth. Either way you get the baby. So whatever way you feel would be the most empowering to you. That's always what I want is my patients to feel empowered. Some people feel empowered in being able to make the decision that they want pain medication and feel like they have a little bit of control there. And some people feel more empowered if they can do it without. And there is no right or wrong. And I always try to tell my patients that it really is your own personal decision. And I have had patients who have tried to go natural and then decided on an epidural and have felt like they failed or did something wrong. And I always tell them, I'm like, listen, with a child, the minute this baby is born, your plans are going to change every second of every day. Right now, you're just changing course. You are still birthing this baby.
Absolutely.
You're just changing direction and doing it a different way. And there's nothing wrong with that. That's not a fail.
Absolutely.
That's just you changed your mind. And this baby, you're going to change your plans all the time. You will never, ever again be set on something because you're trying to get out the door and that baby has a major blowout. You're going to be 30 minutes late. It's going to happen. And so I just try to remind, and it usually makes them laugh because when you're in that much pain and you just want relief, I think a lot of people feel like they're quitting. And I'm like, you're not quitting. You're just changing course.
Absolutely. Have you ever seen like a hypnotic or hypnosis birth?
I have not. I haven't seen any of those. I've heard of them, but I've never personally seen one.
My girlfriend, she practiced hypnosis for, I'd say, like 6 months prior to her birth, and it was her first birth. And she wanted to go all natural. And she was in labor for like 36 hours and did the whole hypnosis thing. She had to have an emergency C-section, but I guess her husband was saying, honey, breathe, use your breathing techniques. And she's like, I am. And then he's like, honey, breathe. And she said, I am. And then he said it again and she punched him in the eye.
Oh. Wow. That was some interesting hypnosis.
I was
Doesn't seem like it was very effective.
like, oh my God. Oh, that's so funny. So I like hearing about those little stories because
Yeah.
I'm like, I might have a freak out too.
Yeah. And you know what? If like I have not met anyone who doesn't have a freak out at some point. Sometimes it's in the beginning stages of labor. Sometimes it's right before you have that baby. And sometimes it's after that baby is born and you realize you're taking it home. But everybody has a freak out.
I can't
Everybody
tell.
does.
I might have one at each stage.
Yeah, that's fair. I totally get that. Usually I will say when patients look at me and they say, I can't do this, they're getting ready to have a baby. Yeah. Because when they get to that point, I'm like, you're about to have a baby.
Oh my God. I don't think I'll ever be able to get through a birth without saying, I can't do this. I can't do this.
Me either. Me either. Because it seems impossible.
Literally.
But they find their way out.
Oh, they do.
They do.
Even when you don't want them to.
No.
Have you ever had a mom just be like, I don't want to do it. Just, I don't want to do it.
Not, I don't want to do it. Definitely, I can't do it. And I'm not ready. I've had some I'm not readies, and I'm like, you're ready.
And like, when will you
fact that
ever
you-
be ready for that?
Right. And that's kind of what I explain is I'm like, if you don't think you're ready, then you're ready. Because being overconfident and feeling like you've got it all under control, like it's kind of the same thing in nursing. Like that's scary because you don't. And knowing what you don't know makes you better at whatever it is.
Oh, absolutely.
So knowing as a nurse, knowing that there's things that you don't know and being able to articulate what they are, that makes you a better nurse. And as a mom, it's going to do the same thing. You know, you're going to say, I need help. And it's okay to ask for help because you just met this person, this tiny person, and they just met you and you're figuring each other out.
And they're going to dictate your entire life.
Yes,
so
they
get
are.
ready.
Yes.
What would you say is the most unexpected thing that's happened in the delivery room so far?
I don't even know how to answer that question because it's always unexpected.
Yeah.
It's never the same. It's never the same.
See, I don't think I'd like that.
Yeah, I love that though.
Really?
I love that it's never the same.
I like predictable.
And I will say, like, I think the thing that makes it different is you're dealing with different people every single time. And so I think one thing I've learned in labor and delivery is you expect the unexpected because 1 second you could think one thing is happening, and then 2 seconds later it is not. So I mean, it's definitely. It is that mix between NICU and Peds ER for me. I still get some contact with the babies. I still get to see them. I get to be the first one that tells them happy birthday, which is pretty cool. I always love doing that. I'm like, happy birthday. And then whatever their name is. Sometimes we don't know their name. It's still up in the air. And then each patient is different in the way that they respond to birth. And so seeing the moments that are like exciting when they first meet their baby
Oh my God.
and the different responses like are so cool. Like getting to, especially when it's somebody who's a new parent and this is their first baby and like you see them become parents, it's so cool. But also, and then even when it's not their first and they're like, oh my gosh, they look so much like their brother or sister, you know, things like that. But it is that mix between PDR and NICU where I get to develop relationships with my patients the majority of the time. Occasionally I am in and out quickly with them as far as like, you know, I might be getting there when they're ready to deliver or something like that. And then I, you know, don't get a lot of time with them, but sometimes I get a long time with these patients. And then I also get to like have that excitement of like, I don't know what's going to happen. It could go one way, it could go the other.
Oh, absolutely. Yeah.
And I think that makes it kind of like exciting for me and kind of, you know, keeps me on my toes.
What is a L&D specific hack you wish you knew earlier?
So there's definitely a few.
Okay.
Finding the baby on the monitor is always a fun thing to do. And so learning kind of like what gestation the patient is and where you might find the baby and what position the baby is in and all of that is all part of the learning process. But contractions sometimes don't pick up. And I remember one of my preceptors teaching me that you can put a penny under, it's called a toco, which is what measures the contractions. You can put a penny in the middle of it or an alcohol swab underneath of it, still in the wrapper. and it will help. For some reason, it helps pick up contractions better. So if you're having a hard time seeing your contraction pattern, if you do that, it helps pick it up.
I've never heard of that.
Yeah, it was a new one for me too.
Yeah.
I feel like for me, it was my first time stepping into the adult world, really.
Okay.
And so there's different things with like easier ways to like hang certain like medications and back prime things that tricks that were taught to me that I just never knew.
Yeah.
I remember the first time my preceptor handed me, she handed me the antibiotic and then the little bag of normal saline. It was like a 100 ml bag.
Oh, the piggyback. You have to learn how to do all that.
Yes, but I hadn't even gotten that far yet. She handed me the green and white, the little thing that
Yeah.
I don't know what it's called. Anyway, she handed it to me, and I looked at her, and I looked at it, and she looked at me, and she actually used to be a NICU nurse as well. And so she looked at me, and she goes, "You don't know what that is, do you?" And I said, "I actually have no idea." I said, "My antibiotics come in a syringe."
Oh, literally.
Except for, the different ones that you have to, mix yourself or whatever, or dilute. But I was like, "No, I have no clue what to do with this." And she's like, "You never worked med surg?" And I said, "No, I did not." And she's like, "Okay, let me show you." And it just made me laugh because she handed it to me I feel like any nurse should know this. And I'm just like, not this nurse.
Oh, yeah, it is very, yeah. I honestly feel like I may have like lost all of that.
Yeah.
Like someone could probably show it to me and I could probably pick it up quickly, but there are a lot of differences between adults and NICU.
Yeah.
Absolutely.
And I didn't realize either like how different it is to care for a patient and then to care for a pregnant patient. Okay. It's very different, and the things that you have to be aware of. And for instance, like what would be your biggest concern with extremely high blood pressure in an adult? You think heart attacks, you think strokes, you think all of that stuff. In a pregnant patient, I'm thinking about high blood pressure. I'm thinking about a seizure. I'm thinking about what preeclampsia looks like. I'm looking at their lab values. I'm looking at their liver enzymes. I'm seeing what that looks like.
Reflexes. Yeah.
And I'm stroke is kind of it's in the back of my mind, but like moderately high blood pressure in a pregnant patient is, it's, I would say severe range blood pressures in a pregnant patient are much more like urgently concerning, I would say. And when I say like severe range, I'm talking like 160 over 110. In some adults, 160 is a baseline for them.
Yeah,
they live there.
Yeah.
But when you have these pregnant patients, you're thinking about blood flow to the baby, and then you don't want to bring the blood pressure down too much, because if you do, then the baby's not getting as much blood flow as they were before, and they're used to that. So then it's like, okay, we have to bring them down, but not too far down, because then the baby is unhappy because the baby's not getting the oxygen that they want. So there's a lot of things that I just never would have thought to consider until, working with pregnant patients.
How long have you worked in L&D?
I've been there since March.
March, okay. Do you feel comfortable yet? Like you really have a grasp?
No. Every day. I mean, I will say that I feel more comfortable than when I started.
Oh, yeah.
But absolutely not. No. I feel like I learn something new every single day. I feel like I'm challenged every single day. I'm still not super comfortable in the operating room. I don't like the operating room. I would rather labor with my patients and, deliver with them. And most of my patients, like that's their goal too. And so when I do have to go back to the OR, it's always a little bit of anxiety provoking, because I am still not super comfortable back there. But I will say I've never gone back to the OR and not felt supported. Our team is fantastic. I feel like I always have people back there with me that know more than I do. And I love that, because then I have someone that I can ask questions to and that is there to help me. So I've never once felt alone, but I still feel like I have so much to learn. Like there's just so much. I don't think in nursing you ever know it all.
Oh, no, yeah. Did you have pre-shift anxiety when you first started at L&D?
Oh, yeah. Oh, yes.
Would you say you still have it now, or has that gone away for the most part?
It's gone away. I had it for the first few months. For sure. And when I say the first few months, I mean the first few months off of orientation.
Oh, yeah.
On orientation, I didn't have as bad of anxiety, but on my own, I did. But I will say, like, the biggest difference that was made was the fact that I feel so supported. And I think that that's truly what has helped me kind of get past that, is knowing that I'm not going to have all the answers, but someone does.
Someone does.
And I know who to call.
Yeah.
And I think too, in the beginning, you don't know everyone's name too, and you're still getting to know people.
Yes.
So that's a little bit of a difficult thing too, because you're like, who do I call? Who is this? What is her last name? Because you're trying to call them on the stupid Vocera. And you're like, what is their last name? I can't remember. And then you're like, wait, they have 2 last names. And it's just, so I feel like that has been, as I've gotten to know people, as I've gotten a little more comfortable in the unit, I feel like that has helped tremendously. So
awesome. Overall, nursing, what is your favorite thing about it?
I feel like I have so many favorite things.
You can say them all.
I love my patients. I love their families. I love getting to leave people better than I find them. I love getting to meet them in a very challenging place and help them get to the other side of it. I really love developing those relationships long term with them, and getting to see their babies grow. Yeah, I mean, I love that there's always somewhere to go in nursing. You're never stuck. There's so many different things you can do. And I think for me, knowing that is really, really helpful, because I am someone who I always want to be challenged. I always want to try something new. I always kind of want to see, what's out there and find, different passions and do extra things on the side and whatever.
Oh, yeah.
And I just feel like nursing opens the doors to so many things. And I love that too. But mostly I would say it's my patients. It really is. Yeah.
Yeah. So what do you plan to focus on in the future?
Okay, so I've got some life changes coming up.
Yeah.
I am in the process of, I think I mentioned it earlier, getting licensed to foster. That has always been on my heart. The joke when I was very little was that I was going to run an orphanage one day. And I always have said when I've interviewed for jobs and they say, if you weren't a nurse, what's the one thing that you would do? And I said I would go to another country. I would open an orphanage and I would just stay there. And I would just love on these babies that need homes. And so I think for me, it's just always been my heart to love these kids and to love their families and hope to see them reunified and hope to help these families and these parents get back on their feet. Sometimes that's not possible, but that's always the goal, is to get them back with their biological family and into a healthy environment. So where they feel safe and loved. And if not, then to be able to offer that forever for them. So I'm starting some new adventures there, which is really exciting in my personal life. Still going to be working in nursing.
Yeah.
I'm not sure what the future holds there, but
So I wanted to ask you, what does becoming licensed look like?
yeah, so there's classes that you have to take in person. There's classes online that you have to take. So many trainings. I feel like I stared at a computer for so long and then did in-person classes. The in-person classes were really, really great because you got to connect with other foster families. And then there's also the preparation of, little plug in here, the preparation of your home.
Yeah.
Which is expensive. When
So what do you have to do?
Yeah, so I don't have kids.
Yeah.
And so I don't have a bunch of kid stuff laying around. I have a few things here and there for the little ones that come to visit me. But I mean, I had to buy a crib, I had to buy a bed, I had to buy, clothes and diapers and pull-ups and bath stuff and feeding stuff and kids plates and cups and pacifiers and blankets and all the swings and just all of that stuff. And so I've actually been really, really blessed. I have a great community and I have a registry and people keep sending me stuff, which is super sweet. I've been very blessed. Like God has just really opened the doors for me to be able to love these kids. And I'm really excited to be able to share them with my circle because they'll get to be loved by them as well. And I love that. And I just I've been very blessed and had a lot of people, come through. And even on I've purchased some things off of Facebook Marketplace and I'll tell people what I'm doing and they'll be like, oh, I have all this other stuff too. The amount of free clothes that people have given me and the amount of just like
Aw.
people that have just sent stuff just to meet a need, knowing that these kiddos just need somewhere to feel safe and loved is really cool. So
We will absolutely put the link to your registry
Wonderful.
in the description box. So please donate if you have the means. So when you foster, are there different levels of fostering? So like,
yes.
so can you take care of special needs or like medical needs?
So there's limitations to each. So you have you have different levels of licensure. So you have your lower level licensure, which is people who choose to take some courses and become licensed for a specific kiddo. So that could be if you have a family friend who wants you to care for their little one. Now, you don't have to have a licensure for that. They can place them with you as long as you can pass that home study. They'll place them with you. But in order to get any type of funding for that kiddo, you do have to have that licensure. So some family and or friends who take in kiddos will get that lower level of licensure just so they can have some assistance for that child to help them with, special things with school or, whatever the case may be. And then you have the foster parent licensure. So that one is just your basic, I say basic, but you're taking in any kiddo. You can give obviously your age range and whatnot. But you're taking in any kiddo who's removed and who needs somewhere safe to be. You won't necessarily know that child. Now there are times where you may have, a friend who's a foster parent who has a child placed with them who can no longer keep that child, but you do know that child. And so the child kind of ends up in your placement. But for the most part, you're taking in kids that you've never met before. And then you have above that, you have medical and therapeutic homes. So therapeutic homes are your homes where you're going to see a lot of kiddos that have a lot of behavioral issues, a lot of significant maybe learning disabilities, kids that have very, very severe trauma. Where they really need to be in that therapeutic environment with someone who is trained to handle that. And then you have your medical homes. Those homes will take kiddos who have those severe medical needs. So if you've got a kiddo who has a trach, or if you have, a child who is on, oxygen or, has certain feeding difficulties, things like that, your medical licensed homes will take those. There's a shortage of all of those homes. There's a shortage of regular foster homes. There really is everywhere. So if they can place that child in a regular home, they will. But sometimes those kiddos do need medical or therapeutic. So for me, for instance, I've told them, I'm able to take certain medical needs, certain ones. If you don't have that medical licensure, you cannot take.
Okay.
Which I'm single and I don't feel like I have the capacity to necessarily take care of some super sick kiddos 24/7 because I feel like they need a stay-at-home parent a lot of times. But I would totally be able to handle a child with like a G-tube or something like that. And so, I've let them know that I'm able to take that.
Does your RN license, does that come into use at any point?
Not really.
Okay.
It gives me knowledge. It gives me experience. But no, not particularly. As far as medical foster care goes, I do believe, and I haven't looked too much into it just because I wasn't looking to get medically licensed, but I do think that you have to have some type of medical training outside of even taking the specific classes. So I do think like you have to be an RN or a doctor or, something of that nature.
I wonder if they provide funding to where like you could be a stay-at-home mom.
Yeah,
for
I'm not sure.
medical.
I'm not sure what they provide. I know that all of the child's medical expenses are covered, but I'm not sure what else they provide for you to be able to care for them. I haven't really looked into that.
Yeah. Yeah, you're just trying to get your toes wet and
Yes,
see how yes.
yes.
Yeah. And how does it work? I feel like I have heard that they can call you on a whim and be like, okay, we have a baby. We need you available in like 4 hours.
Yes. So they will call you with a placement and they will say, we have this child. They'll tell you about the child. You can ask whatever questions you want. And then if you say, I would like to take this placement, you then can ask them, okay, like, what is your time frame? I mean, you can even ask them before that. And you can tell them like, hey, I get off work at this time, I can't be home until then. And usually they'll they'll work around that because it just means that this child is going to have somewhere safe to sleep tonight. But yes, you could get a call, and if you're available, they'll say, okay, we'll be there in 30 minutes.
Oh my God.
It goes from 0 to 60 in 3.5. So yes, it can be very, it can be very exciting, but sad. I mean, we were talking about it actually in my class the other day. You go through all this preparation and you're excited because you're going to go and you're going to love these kids and you're excited to help and love them. But then you have to keep in mind that when these kids come into your home, they're going through probably what has been the worst day of their life. And so you have to keep that in mind, that although you are excited to love on them and welcome them, not that you're excited that they're in foster care, but they are having a really bad day. And so trying to meet them where they're at. And every kiddo is a little different. So
they give me chills. I'm just, those poor babies.
Yes.
They're so lucky to have you.
Oh, I'm excited. I'm excited to love on them. I'm hoping that we don't have a ton of kids in the system, but the truth is there are. So, the hope is always that kids are safe at home and we don't need the system.
When do you become licensed? When are you ready?
So I am moving not far, just moving a little bit further from where I'm at the end of December. And so at that point, I will do my home walkthrough. But there's really no point in doing a home walkthrough before I move because I'm going to move again.
Yeah.
So.
Okay, if you could go back in time and give your baby nurse self one piece of advice, what would that be?
I feel like I would tell myself to slow down.
Okay.
And to not be so hard on myself. I have always been one who wants to do the best, be my best, and wants to get it right away. And that doesn't happen in nursing.
No.
You put me back in the NICU and there's still a million things I don't know. In labor and delivery, there's still a million things I don't know. You throw me on any other floor and I really don't know what I'm doing. So I think taking that pressure off myself and just knowing that I am where God has called me to be and being confident that he knows what he's doing and not pushing myself so much.
Yeah. Enjoy it more.
Yeah, enjoy it more.
Yeah. Okay, so if anyone was to come to you and say, I'm really thinking of becoming a nurse, what would you say and would you recommend it?
Yes, I would recommend it. I would say do it. I love nursing because it's so versatile. I love that there's so many things you can do in it. I have had so many people tell me, oh, I think I want to become a nurse, but I don't really want to do bedside. Or I think I want to become a nurse, but I definitely can't see myself, doing X, Y, and Z. Do it anyway. There's so many things you can do. You can work from home. You can work in a hospital. You can work in a clinic. You can work in aesthetics if you really want to. I mean, there's so many things that you can do that it's a career that there will always be a need. You will always have a job, and you will find your passion in it.
Absolutely.
Yeah.
You do have to get through the hard part. You have to go to the clinicals. You have to show up. You have to do all that.
You do.
But outside of that, you can really do anything you want.
Yeah. Yeah.
Absolutely. Well, thank you so much for coming.
Yeah, thank you.
All right, guys, that's it for this episode. I hope you guys enjoyed. Don't forget to like and subscribe, and we'll see you next Tuesday. Bye.